crisis in bulk billing is widening the gap to access to medical services between those who live in the city and the country, forcing people in some regional centres to wait up to 8 weeks for a doctor's appointment, while new patients are potentially being turned away. A freeze in the Medicare rebate for the past decade has meant GP clinics can no longer afford to bulk bill, which is leaving some patients unable to secure an appointment and thousands of others forced to drive long distances, especially in rural and regional centres, to seek affordable care. And according to the Royal Australian College of General Practitioners President Karen Price, people missing out on an early diagnosis for illnesses are now going to have potentially catastrophic or worsened consequences. Well, joining us today to discuss the widening gap in medical services between those who live in the city and those of us who live in regional Australians is the President of the Royal Australian College of General Practitioners, Karen Price. Welcome, Karen.
Hi there, how are you?
Great, thanks. Now, the situation in regional centres that sees primary health care at a premium for some of us, that impacts the whole system, doesn't it?
Absolutely. The World Health Organization suggests that, primary care is the basis of any good health system. It's the most cost efficient and has the best outcome. So if that fails, the whole system is going to fail.
And why do we have such problems in regional centres? Have we been overlooked by the doctors? Is it hard to keep a general practitioner in the community? Do we need to better connect them to the community? Where are we failing?
It is. It's all about people, and Michael, it's all about connections, and that starts right back in medical schools. A whole range of levers that we've looked at. So, choosing students from rural origin so they can go back to where their family and friends are, the places that they know and love, but also welcoming people who might be on a rotation out into a country area and showing them there is a local kung fu centre they can go to, or a tennis club, or showing them that there are better places than the pizza joint to hang out. So these are the sorts of things that we need to wrap around in terms of showing human beings how they can visualize their life going forward. We also know that we can give them advanced skills. So training them in obstetrics, which we know is in great demand, emergency care, mental health aged care, or anaesthetics, really they want to use those skills. So being able to train people highly, we know is very successful. And the other thing is helping people have that great time. But the longer they spend in a rural environment training, the more likely they are to return.
Yeah, it's what I call the livability of the environment. So the clubs and the communities that bind us all together are so important. Now, are GPs the canary in the coal mine? Because they seem to have been overlooked in a lot of the narrative by the government as far as the recent health crisis goes.
Well, we're certainly rural and remote GPs are the canaries in the coal mine in terms of workforce. So we've got these twin things happening, which is the freezing of the Medicare rebate, which you talked about, which has led to a general decline of interest in general practice. So it used to be 50% of graduates had an interest, and now it's only 13.8%. So that's really startling. And also that rural and remote, most of the medical schools are in cities. So we need to have more rural clinical schools as well. And so we also know that the Deloitte survey has shown that by 2032, we're going to have something like 11,000 GPs shortage across Australia if this continues to go. And so this is going to be what's happening in rural and remote is going to happen everywhere in Australia. And that's unbelievable.
Yeah, and I imagine you can't just bring them in fairly quickly. It's happening in most countries at the moment as well, a shortage of GPs. So we're going to really have to do something to attract overseas already qualified people. And how many years does it take to be a GP now?
Well, it's 10 to 12 years of training, and that's just really beginning. So, and you're right to mention international medical doctors. They've really upheld rural and remote communities. And there's a whole range of discussion around how to do this in a sensible way. There's a lot of red tape around getting an overseas trained doctor into a rural community. It can take 12 to 18 months, and it can take up to sort of $50,000 plus for a practice to bring in that person. That's from substantially similar countries like the UK, Ireland, New Zealand, and so forth. So we need to maintain standards. We need to make sure the people who we bring in have got the same standards as Australians, and we put people through a process at the college. But we also know that there are doctors out there with substantially similar training who are ready, willing, and able to come.
I'm going to ask you a question to put you on the spot here, Karen.
Okay.
Is it frustrating dealing with these bureaucrats, as you said? Because one of the biggest things I know that gets in the way of small business is red tape, permits and bureaucracy. And it seems that they aren't listening to the people on the ground who know the solutions. Is that how you're finding it?
Well, it is frustrating, but we've got a predilection as humans to look for the person who we can blame. And I don't think there is one person. This is the way human minds work. We like to put rules and regulations around things, and then we find we're strangled by it. So what we've got to do is find a way through together with the health department, with the politicians, and with the community. We've got to have a will to have a way forward. We've got to cut through some of this stuff. And obviously there are protections there which are important, but we've got to make it so that it's much more smooth and less red tape like, and not just for the sake of having a rule that someone can justify their job upon.
Now, at the moment, we're seeing billions of dollars promised for new hospitals, for the big, obvious, I'd nearly call them vanity projects, and nothing as far as a rebate, Medicare rebate goes. And Labor has always championed the Medicare. We did it, we'll defend it, and they've run it into the ground. What will it take for them to realise, do you think, that this will negate the need for those billion-dollar hospital expansions to some rate?
Well, I'm trying not to grind my teeth together because it is frustrating to see this. It's a politically palatable situation, and maybe people believe that healthcare resides in a hospital, but the truth is most healthcare occurs in the community, and most healthcare is actually preventative. We know we save more lives as GPs by encouraging people to exercise, by encouraging them not to smoke than a cardiologist does by inserting stents. But we've got to be able to create this health literacy around for our patients. And we know that Denmark, for instance, who they spend 15% of their health budget on primary care and general practice, and they were able to close hospitals because the health of their populations improved. Whereas Australia, we're only spending 7.4% of the health budget on general practice. So to keep spending on hospitals is throwing away good taxpayer money just for a photo opportunity.
Yeah. Now, one of the other things that's getting a lot of media at the moment is the burnout rate of our GPs that have been worked. And there's a frightening statistic, and I'll let you tell it. How many GPs are planning on leaving the practice in the next few years?
Well, there's a figure floating around from our Health of the Nation survey that suggests about 25%. So this is a huge number. And so we've got this leakage at the start of the pipeline of only 13.8% wanting to do general practice. And then in the middle, we've got even younger doctors saying, I want to find alternative employment and reduce face-to-face care. And we've got older doctors who've been the bedrock of our system who are, bringing forward their retirement. And the reason is the moral hazard of healthcare, particularly for general practice, is that Medicare supports very high volume, fast throughput care. So one problem, sit on the chair for 10 minutes, out you go. And that's how Medicare was designed. But we know that care is now much more complex. Mental health goes along with many other conditions, chronic complex conditions. People are living longer, which is great, but they have a higher burden of disease. So, we need longer, more complex consultations. Now, I, as a GP, will know how to manage that. But if I'm being penalised financially for seeing someone for a long period of time and going through all of their issues, that's going to turn me off and create, pain and distress.
And what about digital health? I hear from a lot of doctors that it's just such a shambles, and it could be streamlined so much more to get rid of the bureaucracy and the time-consuming nature that's outside of the consults.
Well, yeah, look, digital health is going to, technology. Look, we're talking on a Zoom conference here, which is fantastic. I couldn't imagine it 10 years ago. So, but it is an adjunct to usual clinical care, and the studies are suggesting that most patients still prefer to see, and most doctors prefer to see each other face to face. But where that's not possible, and in the context of a well-known relationship, so that's the continuity of care issue, it's really important that you can have other means, because maybe you're busy, and maybe we can handle it by phone or by video, and that's the best way to facilitate that care and to keep things going, rather than have you either not get that care, or like a rural or remote person have to give up 3 hours of their time to travel 100 kilometres and there and back just to be told something that they could have been told over the phone. So we support technological advances. We were the first to computerise our practices. We've just got to make sure that it's actually high quality and not dial-a-doc things where you might be speaking to anybody. They may not have a fellowship. Where you might get a quick script. It's never a quick script. That quick script allows your doctor to talk to you about, have you had your skin check? Have you had your colonoscopy? Actually, where are you up to with your mammograms? These things are important little nudges that continue to provide good quality outcomes for patients' healthcare.
Oh, it's great to know that I'm not being shamed for my mammogram. I always feel a bit
Come on,
Now, one of the other things, Karen, is the burnout rate of the doctors, as you said, with that 25% planning on leaving, and with that goes the connection to the patients, their families. I've had a great relationship with my GPs that have seen my daughter, my mum, all through the family, great relationships. It seems at the moment that our esteemed leaders are prepared to treat doctors just as an input into the healthcare costs. So it's just a line item, GPs. And to me, it seems like to treat them as cogs in the machine, that you know that the machine will eventually break, rather than redesign the machine so the cogs last, seems pretty abhorrent, especially when we hear all our frontline workers, we support them, we respect them. Well, doctors are in front of the front line.
That's right. We're the frontest of the front line. We use that cheekily throughout the pandemic. Look, Michael, you're absolutely right. And I've seen your work on the importance of relationships and community, and I really applaud you for that work. What is missing in policy is the understanding of human relationships. And a doctor's output, any worker's output for that matter, if they're in a highly supportive work environment, whether they're a teacher, a doctor, or a nurse, or a childcare worker, they're going to give their all to that place. And that means that the benefits of that go into patient care or student care. We know that young people learn much better in a psychologically safe environment in school. So these human relationships can't be overlooked. They are the basis of our health, they're the basis of our education, they're the basis of our economy, and they're the basis of our communities. That's missing. We've gone into a very transactional model, and I think that's a real shame for our culture, and we really need to look at that. There are lots of things that don't have a line item against them, which are absolutely essential for the well-being and well-running of our communities.
Yeah. Now, I'm going to ask you a big question. I'm not sure where it goes here. We've seen now that one of the biggest predictors for health and outcomes is postcode. If we're talking about medical equity rather than equality, do we need more resources in the more disadvantaged postcodes? Will that help, or will it take away from those that don't need them as much?
Well, you've identified the wicked problem of healthcare, which is what we call the inverse care law. That is, people who've got the least resources often have the greatest healthcare needs. Now, they do tend to cluster in geographic positions and postcodes, but there's also pockets of inequality throughout the community. So, you can be in leafy green areas and you know that someone's on the verge of homelessness because they're in an unstable situation, or they're experiencing, for instance, domestic violence. So we know that these clusters of inequality are everywhere, but they do tend to cluster in postcodes. If we can address our healthcare funding to look after those people, the rest of it pretty much fixes itself. And this applies also to the Aboriginal controlled health sector too. If we can actually invest in those health sectors and lift those people up into high quality healthcare, and for that matter, high quality education, then we are actually going to lift the whole of our communities. So that's an equity issue, an equity of access issue that we need to address. We know that people who are in, say, Rose Bay or Toorak in Melbourne, Rose Bay in Sydney, Toorak in Melbourne, they can probably afford a gap. And by doing so, they actually support other people who can't afford a gap to access healthcare. So this is the way we kind of work as a community. We have all pay taxes to help each other, and it's no different in healthcare. So we need to look at the rational use of our resources, our tax dollars. It can't be, it spread it across everybody and have high quality care for everybody free at the point of access. You get to an NHS type situation where the whole system's choked. So we need to look at the rational use and be really clever. We are a clever country. We've just got to have the will to find the way.
Yeah. My electorate that I'm running for Eureka, we're overrepresented in a lot of chronic lifestyle fueled diseases with asthma and obesity. We have a walk score, I think, the lowest in the state. We've got double the amount of 3-car households because of that walkability and lack of public transport, which entrenches that disadvantage and struggle street type thing. So it's not a surprise. It's as foreseeable as what it is preventable to step back before we get to those billion-dollar hospital builds, to go the small things, the 1%ers will pay a compounding interest over time that will save us so much money. And it's maddening. If somebody like me can see it, I would hate to be the voice in your head when you're listening to some of these polly speak.
Well, this is the thing. I often say that we are palliating very poor policy decisions. So, healthcare is more than what happens between a doctor and a patient. It is also the public health issues and infrastructure that you've just mentioned. So, public transport, having childcare, having domestic violence refuges for people, treating childhood trauma and early life experiences, making sure children have adequate nutrition. Looking after addiction and looking for the mental health that may be sitting underneath that. So, there's a whole range of public policies that need to be enacted within a community to make it a well-being community and not a community that has to rely on a patchwork of band-aid solutions. That's absolutely not the way to run healthcare.
Yeah, we service our cars more than we service ourselves, and we don't wait until it breaks down. Anyway, Karen Price, love your work. Pass on my congratulations. And last night I was at Joe Garra's
Joe.
launch, and I mentioned to him that I was speaking to you today, and he said hello. And I worry one more great doctor out of the system, should he be elected, and I hope he will. What are we going to do?
Well, I think let's see what happens. I think we've got an appetite for change in our society. We've got to, look after each other in the communities, and if that's what each politician can do for us, then great. Joe may well achieve more by being a politician than he could seeing each patient. But I'm sure that the people in Werribee are going to miss him. My son lives over in Werribee, and I just want to say a shout out to all the Eureka people there, because Eureka, I was born on Eureka Stockade Day. So keep on going, guys, and invest in good local solutions.
Yep, that's it. Independent candidates that are committed, accountable, and loyal to the community, and not partisan political point scoring, is where we'll change things. And Joe's a prime example of it. And I think he'll get up, and hopefully I'll get to sit on the crossbench from him.
All righty. Good on you.
Thanks so much. Thanks, Karen.
Bye-bye.